Well, good morning. This is Pat Justice, and I'm the director of the Rural Health section at Washington State Department of Health and the leader of this palliative care initiative that's kicking off with this webinar this morning. And Tammy, I just want to check with you if there are any other instructions that you'd like to give participants before I get rolling.
No, I think it's good as long as everyone makes sure that their microphone is muted. Again, the mute button's on the lower left-hand side of the screen if you have your mouse over it. And then when it's time for question and answer, they can just unmute. Thanks, Pat.
Thank you. And this morning, we're going to hold questions until we get going just a little bit. And in just a minute, I'm going to give a little bit of an overview, talk about our objectives today, and I'll introduce our speakers. We're not going to do this as a traditional PowerPoint presentation. We're going to do this talk show style as a conversation. I've experimented with that in the past and find that that gets it rather lively, and I think both of our speakers today have a lot of passion and knowledge that'll come through best in a conversation. So to get started, I want to first offer thanks to the National Regional Telehealth Resource Center who helped us do this webinar, Northwest Rural Health Network that is helping us do the platform, our office team, and also the Northwest Rural Health Network, and then all members of the Palliative Care Rural Health Integration Advisory Team who worked hard and long to begin shaping a project that we're going to tell you just a bit about this morning as we get started. So today what we want to do is describe the goal of that initiative, and then we'll launch into more content about defining and comparing both palliative care and hospice, addressing some common myths. We want to talk about the kinds of patients that can benefit from this broader kind of palliative care, some of the benefits, and explore what healing might mean in the context of serious and life-threatening conditions. And we may do more than that, but that's our beginning list. I'm going to share this cartoon. You've got 6 months, but with aggressive treatment, we can help make that seem much longer. So this gets at the why do all of this? And it's because with the best of intentions, some of our treatments don't make things better, and they actually make things worse in terms of quality of life. And it's my sense, and I think many people's sense, that that happens because people don't understand that there are alternatives, and they don't want to just do nothing because that feels really helpless when people are having a difficult time. So I hope that today that you come out with a sense that there are some things to do besides aggressive treatment, and we'll talk more about what all that means. So just a bit about this project. Our goal is to assist rural health systems and their communities to integrate palliative care in multiple settings so that they can better serve patients and families in rural communities. And we know that in a rural community, you're not going to be able to probably stand up a freestanding palliative care service with a large interdisciplinary or multidisciplinary team. But we think there are many things you can do to integrate it with existing team members and then seek guidance through other means to bring the expertise into the community. And so we're going to be talking about that. This initiative will use the model for improvement and test small changes. And we hope to develop funding models for sustainable service. We're aware that the funding for palliative care in the larger sense is a patchwork quilt of bits, sort of kibbles and bits. And we're dedicated to try to make it better in Washington State and to come up with some models that really can sustain a wider selection of services. So this diagram is gets at sort of the wider thing. When we talk about palliative care, and I'm going to have the speakers go into this in more depth, but just at a basic level, we're not just talking about hospice, and we're really talking about people who are challenged living with serious and life-limiting or life-threatening conditions. And as you can see in the diagram, there's some overlap with chronic disease or disease management in the center where there's some focus on symptom management and quality of life. And I think that both Dr. Van de Kief and Dr. Grossman can really explore sort of where those gray areas are. How do you know who to put in or out? This came from the University of British Columbia, and I think the interesting thing about this diagram, as opposed to some others, that it shows that some people actually go into rehabilitation and survivorship rather than, on a trajectory to die. So I think that's important for us to consider. So this is a picture of the model the initiative is working from. So you see that we've got community engagement and education as a primary piece of what we're going to do. direct telemedicine services for patients and families, clinical team culture change, training and technical assistance, so that would be in the healthcare settings, the ability to do a case consultation through telehealth. Some people call it Project Echo. I don't think we're going to call it that, but similar to that. And then that center circle, inside that circle, by the way, would be the patient and family, but rural health clinics and critical access hospitals and other settings would work in tight coordination with existing home health and hospice services. This is in no way meant to supplant that, but rather to wrap around that. And the level of those services really vary from community to community. And then, as I said, sustainable funding being that bottom stream, kind of phase 2 is we hope to develop rural centers of excellence. We are going to begin with a cohort of 6 communities, but we think that many of the things we do are going to be available to the wider rural health audience in the state. Around the telehealth piece in particular, we think that there's going to be a developmental pathway where we begin with the case consultation training side of things and then move into direct telemedicine from health organization sites. But where we'd like to be, the vision is eventually be able to do home-based telemedicine where patients and families can remain at home or if they have homebound status and receive palliative care directly via telemedicine. But we'll have to start more modestly with the case consultation and then work from there. Where we are in this initiative is we've had an advisory team that has worked on a conceptual model, and that sort of phase is complete in a sense. We're now in work groups working on implementation planning and our cohort selection for this first group of 6 communities. We'll move to testing and refinement in those communities, and then we'll be looking how to spread to additional communities. And as I said, we'll be looking at training opportunities absolutely for Washington rural health communities at large while we're still working with a smaller set on some other things. So now to introduce our speakers. Dr. Vanderkeef serves as the Southwest Washington Regional Medical Director for Palliative Care for Providence St. Joseph Health, including inpatient consulting services in Olympia and Centralia and an outpatient clinic in Lacey. He's also the Associate Medical Director for the Providence Institute for Human Caring in Torrance, California, which serves multiple states, as you can see there. He's going to be joined in the conversation by David Grossman, a physician who's a clinical professor and assistant dean for student learning communities and student affairs at the new Elson S. Floyd College of Medicine at Washington State University. They just welcomed their very first class not very long ago. He came to Washington from Ohio, where he served as the director of 2 hospice and palliative care programs and as a professor and faculty member of the Northeastern Ohio Medical University and the Ohio University Heritage College of Medicine. Give me just a moment. I'm going to get out of these slides, and then we'll get rolling. Okay. So I'm going to open up a question, and Dr. Vanderkeef, maybe you could take off with it, and then we'll have Dr. Grossman join you in that question. So the first question has to do with the definition. And so when you think about the differences between palliative care and hospice and where that kind of lines up with also chronic illness management, where those lines and gray areas are, could you talk about that, how you see that?
Thanks, Pat. Yes. Can you hear me okay?
Yes.
Okay. So one of the things I've recently appreciated, I heard Diane Meyer speak on this spring, is the importance for palliative care to get away from defining ourselves by what we're not and defining ourselves instead by what we are. The reason that comes up is, as you pointed out, distinguishing palliative care from hospice, distinguishing palliative care from end-of-life care. When we start by defining by what we're not, it's a little bit of that don't think of an elephant sort of thing. Well, now that's what's in your mind. And so I've really shifted to more and more emphasizing palliative care as supportive care, that we assist in complex symptom management, navigating one's way through a complex healthcare system, making difficult medical decisions in the face of serious illness. And that really emphasizes both what we do and palliative care as more of a type of service. When you get into hospice, which was specifically a part of your question, that is one specific defined model of palliative care. It's a payer source. There's a set of benefits tied to it. There's a whole regulatory framework around it. So it's just one particular model, whereas palliative care is a much broader concept of care. And I'll defer now to Dr. Grossman.
Thanks, Greg. Good morning, all. You know, I think if we're thinking about patients who have chronic illnesses, and those illnesses may limit their life expectancy, congestive heart failure, end-stage diabetes, end-stage kidney disease, advanced dementia, diseases that affect organ systems that don't seem to be causing the patient to be in imminent concern of death, but a disease process that may limit their life expectancy. Maybe it'll be 9 to 12 months, maybe longer. As you begin to think of those patients, I think it's appropriate then to think in terms of palliative care, because the question becomes, how can we improve their quality of life? How can we manage their symptoms, be it pain or anxiety or depression, sleeplessness? How can we focus on the goals of care that they may bring to us? Perhaps they want to anticipate the wedding of a grandchild or the birth of a grandchild, those kinds of events. And so we come into play early and we try to improve the quality. And it's an ongoing conversation, because their goals of care today may be to continue aggressive chemotherapy or radiation or aggressive care of their underlying illness. And in a month from now, they may decide, no, they just want to focus on symptoms. I think as we move through the spectrum and focus on symptom management only, and their life expectancy then seems to be shorter, perhaps 6 months or less, that's when we begin to have the conversation about what hospice can offer them.
Greg, did you want to respond to any parts of that before we move to another question? Or, excuse me, Dr. Vanderkeef, I'm not sure which to call you on this.
Greg works fine. The one thing what I'll loop back to is something you said, Pat, which is that bow tie diagram, where you emphasize the element of palliative care being involved in survivorship. The historical models we've looked at have always been sort of a trajectory towards end-of-life care. And I really like that the bow tie diagram that you used also emphasizes that frequently we're caring for patients who are in remission, who have years, maybe even decades of life ahead, but they still are someone who would benefit from palliative care as they move forward in their illness. And so I appreciated your selection of that particular diagram.
Yeah, thanks. I heard Joanne Lynn talk one time, and she talked about how, you know, with infectious disease, a while ago, it was true that people, you know, there was sort of this clear trajectory when you knew when they were dying. But with chronic illness, someone can be going along and then over a weekend enter their last stages unexpectedly, in a sense, but they go for quite a long time. So it's not like there's a neat trajectory with chronic conditions. So could you talk about, and I think this got addressed a little bit, but when you think about a patient who's not dying yet, what are some of the benefits that they see from palliative care? You start us off, Greg, and then we'll move to Dr. Grossman.
So I met a new gentleman in clinic yesterday with advanced Parkinson's disease, and I think the main thing we accomplished during that encounter was establishment of rapport. I expect that he has many months, maybe years of life ahead. And so he has some complex things to manage, both medically and within family considerations. And by not waiting until he's in a more dire circumstance, I really feel like the establishment of rapport, getting to know one another, getting to understand his and his family's values, needs, treatment goals, treatment preferences will enable us to help assure that the care over whether it's months or years ahead will best match what's most appropriate for this gentleman and his family. And then as the symptoms become more substantial, as his function declines, if we need to get into conversations about hospice care, end-of-life care, we're coming at it from a different perspective because of that time. Anybody that's worked in hospice will tell you a very similar story, that if they get called in with only days to a couple of weeks remaining, they are really less equipped to then meet all the needs the patient and family have than if they get called in with many weeks to perhaps months of life ahead. So just really extending that time frame, and perhaps with somebody that has more of a complex chronic illness as opposed to an imminently terminal illness.
Dr. Grossman?
Yes, and I agree completely. That trajectory changes. Sometimes we think we know what it's going to be. Sometimes, as you say, an intercurrent illness comes into play. They develop pneumonia, they have a fall, they have a broken hip, some other issue comes into play. I think it's just important to continue the conversation on an ongoing basis. What is quality of life for that particular patient, and of course their extended family? How do they view these things? Because someone, for instance, with heart failure has a limited life expectancy. If they undergo surgery, they have a valve replaced, they have a bypass, that may change the trajectory from where it is today. But I think having the conversation with the patient, what would you like if you were to develop increasing symptoms over a few days? What would happen if you came to the hospital unable to breathe? How would you feel about being placed on artificial life support, a ventilator? How would the patient with Parkinson's disease or advanced dementia feel about artificial nutrition and hydration? Having those conversations regularly will help predict the course of treatment and how aggressive or how symptom management focused we should be. And I think that families and patients change their mind frequently, and I think we have to adjust to that. Sometimes hospice becomes appropriate within a few hours or a few days. A patient's been going along in palliative care for some time, been very stable, something has come up, and we decide now we want to completely change the focus just towards symptom management, just towards making them comfortable in the final time in their life, and hospice comes into play. Hospice can be taken away also. Some patients, as we affectionately say, graduate from hospice. They do better than we expect. They go through rehab and perhaps they continue back into a palliative care mode for some time.
Thank you. I'm struck that when we talk about this, that there are some patients who have chronic conditions, and that term of whether it's life-limiting or not, you could take that as time, or you can take that as it makes hard to live. So start with you, Dr. Grossman, this time. When you think about those patients who have chronic conditions, but you wouldn't necessarily include them, and I'm sorry, Dr. Vandekeep, this is sort of doing the knot, but which patients would you not be inclusive of in a palliative care model, and why?
Well, I think patients who come in with an acute episode, somebody who's elderly, who has maybe 4 or 5 chronic medical problems, but is doing very well, very compensated early on, and they end up with pneumonia. A conversation can be started, but perhaps they're too early. I mean, when we think about palliative care, we think about people with chronic illnesses, so we really could start quite early. But perhaps the primary care doctor, the family doctor, the internist can comfortably manage those symptoms at that point, and they would consult with a team. We would talk about how we could continue to make them more comfortable. We could focus more on their breathing or their sleep, their bowels, their anxiety, and then we might fade away and come back into play as symptoms progress. So it's not that it would be inappropriate, but I think it would be a timely manner of, we want the relationship between the primary caregivers and the patient and family to continue. But as Greg so aptly said, being involved early in palliative care or hospice allows you to develop a relationship, to get a sense of who the patient and the family are, what their needs really are. Because when we come into play a few days or a few hours before death, we don't have a chance for our chaplains, for our social workers, for our nurses' aides, for our nurses to get to know the patient and the family very well. And then we're just kind of, we're patching, we're trying to patch together a last minute plan to allow for comfort. And that's when the public sees us as morphine and Ativan and the patient dies. Because if somebody comes into hospice in the 11th hour, oftentimes they need medications for end-of-life comfort, and that's kind of what we do. And then they look at it in terms of cause and effect. Hospice came into play. They gave certain medications. We assisted the patient with death. And there's so much more we can do when we can begin early. So I think if any message, if you're thinking in terms of palliative care, if you're thinking in terms of a life-limiting condition, call the palliative care team, because they can certainly advise you as to where they think things are in the course. And then they've made the connection with the patient and family early. They can always be brought in again and again.
Great.
Yeah, thank you for that, Steve. One of the things that I always remind myself is when we talk about palliative care, we're often making assumptions about the provision of a specialized service, typically with an interdisciplinary team. And yet so much of palliative care is actually ideally delivered by a person's primary care provider. And so I like to think beyond the specialized service. And so learning, improving one's ability to communicate around prognosis, treatment goals, et cetera, to manage complex symptoms, and then recognizing when things do rise to the level of benefiting from consulting a specialized service. I like what Steve said earlier about calling the team as well, particularly for a newer field. We're struggling to define ourselves, and so it's only natural that others are struggling to define who would be an appropriate patient. And so we actually, both through our nurses who triage all referrals and through our providers who will frequently call a referring provider to sort of inquire, what are you hoping for out of this consult? So looping all the way back to your question, the area that I struggle with the most about quote unquote who's appropriate or not is around chronic non-terminal pain issues. We have a terrible deficit of interdisciplinary services for chronic pain sufferers. And so for persons looking for help when their primary care providers exceeded their comfort level, their skill level, their morphine daily equivalent level, and they need assistance, they're looking for who can we turn to. We need to be cautious in palliative care, because if we start becoming a chronic pain clinic, all of our available appointment slots will fill up fairly quickly, and we will have less availability to people who might be more of a traditional palliative care patient. And so we do a lot of dialogue with referring providers and spend a lot of time reviewing charts to try and make sure. It can be a double-edged sword, because CAPC, the Center to Advance Palliative Care, and many other organizations really promote that palliative care can be appropriate at any point along the illness trajectory. If we then turn around and say, but that patient's not life limited enough to qualify for our palliative care service, it really sends a mixed message. And so I think we need to be mindful about how we go about reviewing cases and discerning whether or not they are somebody who would benefit from coming into our clinic.
And if I could loop into that too, and I certainly agree with Greg. We have patients who have longstanding relationships with their primary docs, but oftentimes because of this relationship and because of the closeness, they're reluctant to have that talk with the patient. You do have a chronic illness now, and it will be life-limiting. They don't perhaps want to appear as giving up or throwing the towel in on their patient. And so they often consult us to have that conversation, to try to realistically allow the patient to understand that perhaps their life is going to be limited by this. We're not certain how long, but now we want to change our trajectory. We want not our trajectory, but our focus. And we can often help the primary docs do that and then hand the care back to them. The opioid piece is very important. Lots of physicians, especially today in the climate of over opiate use and abuse, are very reluctant to give opiates to their patients. And we have to be careful. We're not interested in generally taking care of 28-year-olds who have chronic back pain, who don't have a life-limiting illness. But we are interested in people who have severe chronic pain related to an underlying condition, perhaps their malignancy, perhaps end-stage organ failure in terms of diabetes or kidney disease and that sort of thing. So we can often help manage those medications or advise out those medications. And oftentimes, and I'm sure Greg will agree, we come into play, we make a suggestion about a particular medicine tweak something a little bit or just add a small dose of something. And the quality of the patient's life is much improved, and they continue to go on and function and be an active part of their family and society. So oftentimes it doesn't really take very much. It takes listening to their story, finding out what they've used that's worked or hasn't worked, and then making some suggestions. And I think most patients resonate with quality of life. Everybody wants to live a long time, but they don't want to live a long time uncomfortably. They want good quality. They want to be able to enjoy the things that are important to them.
And I think one of the motivators for us with this project is, and for people who live rural, they've selected to live there, or they've lived there all their lives, and to leave that area when you're feeling your worst can be pretty traumatic. And so you both have talked about interactions with the healthcare team and the role that palliative care specialists might play. And I know there's a model, and we're not showing it, but of primary, secondary, and tertiary palliative care. So I'm going to give you sort of a two-part question. Could one of you, explain what that means, and then talk about that in relationship to an existing rural healthcare team, how you would think about how those levels of palliative care intersect with that local team. And let's put in one more ingredient that we have been working on, a training package for that local team. So they're developing their skills and knowledge, and they've got some of those pieces. So I'm giving you some nuance there. And Stephen, you want to start out with that one?
Well, I think that education, the more we can educate the caregivers at the primary level, be it rural or within a healthcare system, the better we are. I mean, we want to spread the message to begin with. And then from spreading the message, we want to focus on the quality of life of that particular patient and that particular situation. And then we move to more advanced care of their symptoms, more nuanced care of pain management or symptom management, always sharing that information back and forth with the primary caregivers, because ultimately they should be part of that team, be it a nurse practitioner or be it the nurses around that patient through a home health program or through the palliative care services. These are team approaches, and I can't emphasize that enough, and I know that you and Greg have mentioned that. We function as a team. Palliative care and hospice are the preeminent team players. We cannot do this alone. We often glean information about what quality of life means for a patient based on what our chaplain tells us, or sometimes it's the housekeeper when they're in an inpatient unit in the hospital. They tell us that they've been estranged from a child, or they have a child who's out of town or perhaps in prison that they haven't seen for some time. So all those layers of connectivity that we can focus on to improve their quality of life, always having a dialogue back and forth with the primary care team. And there may be a time when the primary care team hands that responsibility off to the palliative care team or the hospice team, and that's fine, but that conversation occurs regularly.
Great.
Yeah, I appreciate, Steve, how you've really nicely outlined a collaborative care model. And we find that we're getting an increasing number of referrals where they're not asking us to take on the management of the person, but to rather provide consultation and direction, and then to know the person and be available as a resource. I think back to when I was practicing full spectrum family medicine. We had very limited access to psychiatry, and some of my complicated mental health patients, schizophrenia, bipolar disorder, the psychiatrist would see them once or twice a year, and I would do all the interim management as the person's family physician. And I see us often benefiting by functioning in a similar capacity, evaluating the patient, making a phone call back, sometimes communicating via the electronic record, and then being available for that phone call when somebody can call in to say, hey, Greg, John Doe is having the following, and I don't know that he's going to be able to drive an hour to your clinic because we have a fairly wide referral area throughout Southwest Washington. How can we help people in that sense? And then also Steve's earlier comment regarding education, really working hard in primary care groups to be able to enhance that ability to ask the difficult questions, or just to ask the fundamental questions. So often as doctors, we walk into a room and we start talking. without doing a lot of asking, and getting a better ability to say, tell me what you understand about your situation. What do you expect your illness will do in the future? What your life will be like in the future, given your current circumstances? And then my favorite question is, as you've assimilated all this information, thought about your future, what are you hoping for? And really finding out, because sometimes it's a very practical, I just want my pain under control. Other times it moves into an area that frequently I'm really grateful to have a social worker or a chaplain with me, because the person really, when they think about their future and what they're hoping for, it may not be in the medical model. It may be something more existential, familial. There are a lot of different ways people can take that question. And the beauty of the interdisciplinary team, we each have certain skills in those domains, but I can turn to somebody who is an expert in understanding those things in a way that I can't be. And so that model works really well for me.
And I can't agree with Greg enough. So often and early on in my career, I was told, all pain is not physical. And you begin to manage someone's pain and you get a call from a primary doctor and they say, I just can't get this pain under control. And that's when the light goes off that says, well, maybe that pain is coming from another source. Maybe they need to speak with our chaplain first. Maybe there's an issue that we haven't dealt with, because morphine will manage many kinds of pain, as will other narcotics, but it won't take the sorrow of the loss of a child early in life, or perhaps the loss of a loss of a pregnancy early in life that now comes back to haunt them as they approach the end of their life. So we truly need the team. We need a 360-degree view, and we need to educate. I've given so many lectures to so many groups and still have multiple physicians come up to me and we get asked the same question. Is it time for palliative care? It's too early. They often feel like it's too early. Doctors, despite their training, and the training is evolving, and I know this from being part of the medical school, they don't feel that they should give up at any point in time. And sometimes the family or the patient has to almost beg with a doctor to say, I've tried the chemo, I've tried the radiation, I've tried the treatment, and I'm ready to just allow things to play out as they are. And it's a tough story for most physicians to hear. I did family medicine for 20 years also. And I think back in that day, we did a lot of our own palliative care because we had long-standing relationship with the family. It's nice to have experts who understand the use of narcotics in particular, and sometimes just the addition of something to help sleep, sometimes something to just help their anxiety can make a huge difference in the quality of life. But it takes everybody in the team to focus on what the patient is really saying. And sometimes they're not telling it to you in easily understood terms. They're skirting the issue, and we have to be very thoughtful and be good listeners.
I'm also reminded that in our culture, we frequently use the language of pain to describe what I would call suffering. That's a sort of multi-dimensional sense of psychological, spiritual distress that people often don't express in those terms. They come in and talk about pain. That's exacerbated by the fact that we in medicine are really not trained well in how to bear witness to other suffering. And Amanda Cost from the University of Washington just published a beautiful article in the Society of Teachers of Family Medicine Journal on the whole issue of dealing with suffering and how complex that can be, and how we really need to have proper training and understanding of working with individuals who are going through those sorts of difficult things if we're going to truly meet their needs. It's not just about the medications, the pathophysiology, but there's a whole lot more that we need to be able to meet on behalf of the patients.
And I saw a patient not that long ago, and the patient had come in with a multitude of symptoms. And within a couple of days, we had thought that we had done a very good job managing those symptoms. The pain seemed to be less, the anxiety seemed to be less, et cetera, et cetera. And when I talked to a close family member, I said, well, how are you perceiving what's going on with your loved one? And they said, well, they're suffering. And I said, their pain seems to be better. They seem to be sleeping, et cetera, as Greg has alluded. But they said, but they're suffering. And that opened a whole different discussion as to how we could mitigate some of their suffering, what we could do perhaps to make that better. And sometimes it was just sitting at their side, not allowing them to be alone. Sometimes it was distraction with other kinds of things, maybe music and so forth. But that suffering that Greg alluded to is a very important piece. And, you know we can make your arm feel better with enough narcotic, but that doesn't take away the issue that your life is going to be shortened and you're not going to see certain events in the future that you anticipated seeing. And that suffering is a difficult thing to manage and requires a lot of thoughtful work. And we can't cure it all. We can't make it all better, but we can certainly attempt to.
So both of you have been talking about the family. And, you know, one of the things I love about both hospice, palliative care, and frankly, pediatrics and psychiatry are that they pay a different level of attention to the family. So can you talk about how the family is engaged in this kind of care? And, you know, just reflecting, I think for any of us, there's nothing probably harder than watching a family member suffer. And it's sometimes harder than suffering ourselves. So what does this offer family members, and what kinds of help is there for the family?
Well, one thing I think we really focus on is legacy. What will the family be left with after the patient is gone when we're talking in terms of end-of-life care? And sometimes we can be very proactive about that, actually doing journaling, audio recording, video recording, things like that to help get a loved one's stories down so that they can be preserved and help for others. Other times it's around just something as fundamental as caregiving. What are we going to do to address the need of the caregivers in the home? The gentleman I mentioned earlier, I met yesterday with Parkinson's disease. Part of the reason they were coming in to see me is his wife is getting to the point she's having a difficult time meeting his needs physically. When he gets down on the floor because of his Parkinson's, it's a struggle to try and get him up on his feet. So spending time with her, talking about her needs. When I sent my note back to their family doctor, I very specifically called out some of what she was going through, and if he's also her family doctor, that he's going to want to take her concerns into account. Having some resources available to get caregiving help out into the home. And then also finding out what about the children? Is everybody on the same page? You know, we often joke about the son from California syndrome, where somebody's going to come in from out of town and see things differently and stir everything up. I actually ask families during an initial consult, do you have somebody who's going to stir things up, who's going to see things differently? And just about everybody understands where that question's coming from because they've seen it happen to somebody else's family. And so taking all those things into account is really critical in my mind. And thinking about after their loved one is gone, how is our care going to impact the memories, the legacy that the family carries forward? We can't create reconciliation or the sort of warm, fuzzy things we often think can take place at the end of life, but we can sure be a barrier to it. If we don't give honest prognosis, if we don't allow them to maybe choose a different pathway other than one more trip to the ER and the ICU, we may actually be a barrier to them being able to process the sort of important things a family is going to need to go through. And then they're going to be left with more guilt, frustration, anger, incompleteness, all of those things as their legacy. And so we try to be really mindful about that.
Beautifully said, Greg. I couldn't agree with you more. You know, the only other thing that I would add is how difficult it is for some of the caregivers. You have a disease like Parkinson's where it may go on for a long, long time. The caregiver doesn't get the attention oftentimes that the patient does. I mean, we manage patients' pain and restlessness and sleep and so forth, but we don't do much to manage the caregiver. And so a support system built around allowing that person to get out of the house to enjoy some of the things that they enjoy without the responsibility of caregiving is very important. And our systems aren't very good at taking care of caregivers. And we often have patients come to us who've been treating for an ongoing cancer for, you know, a decade or longer with ups and downs. And the wife or the brother or the sister or whoever, the child has been dealing with that for so long that it's so debilitating for them, that we need to be very mindful of that. I think one of the things that we can do by keeping patients in their home and providing care through telehealth and the nuances thereof is to allow the support of the family and their community or their church or their friends to aid in that comfort. Because if we bring them to a medical center a long way away or put them into an inpatient hospice unit where they don't have the local support, it becomes very difficult. So we have to look at the family as being integral. A lot of my colleagues say, well, I don't need to share this information with the family because, my relationship is one-on-one with the patient. But I think that that's naive. I think that there are certain legalities to this, but I think it's naive not to get the input from loved ones, especially as Greg mentioned, the child from out of town who has now heard about somebody who took a particular treatment or did a trial of medicine out of the country that made a big difference. They are pot stirrers, and we have to bring them into the conversation and listen carefully to what they have to say, and try to help them make the best decision for their situation.
Some of you are familiar with Don Berwick, who ran the Institute for Healthcare Improvement, and when he, for a time, was leading CMMI, he was accused of death squads, and I think this hurt his feelings deeply. But the whole sense that people can misunderstand about rationing care, if you're not doing everything, are you taking something away? Can you speak to that? And pretty soon I want to assure the audience that we're going to open it up. There's a number of you who are palliative care experts out there as well, and so we're going to get this conversation a little wider here in just a moment. But can you respond to that, either of you?
Yeah, go ahead, Greg.
I was just going to say, if people were to observe the care provided, the whole death panel or death squad accusations would fall away instantaneously, because we spend a tremendous amount of time exploring a patient's and family's understanding of their situation, helping them to understand what the anticipated clinical course will likely be, what their treatment options are, and then helping guide them and to choose the treatment options that are most appropriate for them. It just so happens that frequently people will choose a less technically comprehensive approach to treatment, a less invasive approach to treatment. That's not withholding anything of value. If we really question whether they ought to do it, we're going to encourage them. There are times when I get called in to evaluate a person with the hopes that, or the expectation I'll put them on comfort care in the hospital, and I come out and I say that it's not time. They really still do have treatment options they want to pursue, and we ought to do that. And so the whole accusation around death squads or death panels is much more political, or to serve a non-clinical agenda. When you really spend time doing this work, it's about defining what the patient understands, what they want, and helping match them up with the correct service.
And I think if you have a good working relationship with the people who you deal with in your hospital systems, for instance, I have been called in to encourage patients to undergo more aggressive care when the prognosis seemed much better than had been painted perhaps by someone else. Convince an individual to go on a ventilator for a few days to help them get over their pneumonia. Yes, they have an underlying chronic illness, but the team feels that they would survive this. So if we have a good working relationship, we can be used as advocates for a more aggressive care or less aggressive care. One of my enlightened intensive care colleagues used to bring the family to the doorway and of an intensive care patient, and they'd say, now look in this room and look at all the tubes and look at the machinery, and tell me that you can't understand that the life expectancy of your loved one is probably going to be shortened. And then he would step back and say, we might be able to get them over this particular hump, but my guess is that in 6 months, they'll be facing the same sort of a thing again. So do we want to go forward at this point, or do we want to drop back and focus on their quality of life? And sometimes just the visual of all the apparatus around the patient would help them see that how sick their loved one is, because they often don't want to see that, and who would? You know, the patient is never old enough to be ready to die unless they're in terrible pain, or perhaps if they've reached their 100th year. But you know, every family thinks that they can. I remember the first time I took care of a 104-year-old, and he was getting close to death, and the family came in and they said, well, we just thought he would continue to go. I mean, he had said he was going to die in his 70s and then 80s and 90s, and now we were over 100. And so they suspended the reality of how old he really was. And they were shocked that we were going to have a conversation about life being short at that point. So, you know, we're all hopeful. But in the end, as Greg alluded, most patients choose less invasive care. They really want to be comfortable. They either want to be home or they want to be close to their family. There are exceptions, but for the most part, that whole pulling the plug on grandma, if we do a good job painting the picture of where they are and where we think they're going to be in the next few months, few weeks, then we can often get them to understand the reality of their disease.
I've got one last question, and then it's an open forum. So, you know, medicine is both science and art. And how would each of you talk about the art of this work? What do you think is the artistic side of caring for people in this way?
I imagine that many families come up to Greg after he's had an initial conversation and say things like, oh my goodness, this is the work that you should be doing. You're so good at this. You're so thoughtful. You're so understanding. I think that most of what we do is we're present. We listen to their story. And I've often had to say to myself, I say, well, tell me what you think the outcome is, or tell me your story from the beginning of diagnosis. And I would sit down. I often made rounds in the past with my collie, my dog at work, and we'd sit down in a comfortable place, without any distractions, and you'd listen to the patient and the family tell their story. And once they'd gone through the whole process, well, we went here and they didn't respond to us, and the doctor was supposed to call back, and there was a delay in the diagnosis, and the biopsy didn't come back, and it was equivocal, and you know, on and on and on. They've told that story. They feel relieved, and then at that point in time, you've established your presence, and you let them know why you're there. You're there to hear their story, to bear witness, as Greg said, and try to do your best to take care of their suffering, listening to what their goals are, listening to what they define as quality of life. I remember going to see a patient who had end-stage heart failure. I walked into a home visit. She had extremely swollen legs. I'm thinking all about how I'm going to better manage her heart failure. And when I began to ask her what was troubling her, she had wax in her ears. She couldn't hear the radio. She was already blind. And that was her outlet to the rest of the world. And so I irrigated her ears, took the wax out. She could have cared less about her legs being swollen. She had gotten used to the fact that she would always be short of breath and needing oxygen. And once she could hear her shows on the radio, her quality of life improved again. So it was a useful message that we have to listen to their priorities. We are taught to prioritize based on urgency and severity of that particular disease or that illness. And what we have to rearrange is, what is your priority at this point? It may not be the swollen legs or the shortness of breath. It may be something as simple as I can't hear the radio.
Yeah, when I think about the difference between science and art, it reminds me of also the distinction between curing and healing. Curing is very much about the science of medicine. It's focused on the disease and what can we do to either fix the underlying condition or at least ameliorate its effects. Healing is a much more multidimensional process. It involves, again, psyche, spirit, family, other things. And I have seen profound examples of healing in the final days of life. Cure was impossible, but families who've reconciled estrangements, patients who've had just the right encounter in the healthcare system, or perhaps with a family or clergy, where that to me is where the art of healing really comes in, is knowing how to listen. I like your example, Steve, about presence. I mean, it took me a long time as a physician to really formally understand that sometimes simply being there is what mattered most. I kept thinking I needed to find the right words or make the right diagnosis or write the right prescription. And over time, I came to appreciate those things are important. I don't mean to diminish them, but sometimes that presence is what mattered the most. And even in an encounter I went in recently while I was rounding in the hospital with a tremendously effective communicator I work with. He's in a different specialty. But as I walked out, I noticed he did all the talking. The family hardly talked at all. And I really encourage the residents and students I work with to observe the percentage of time that the clinician talks versus the patient and family. And really, the patient and family ought to be speaking over 50% of the type of encounters we're doing. And that, again, it builds trust. It helps establish an understanding and leads us to be better clinicians because we can better meet the needs of these individuals by understanding them better.
Amen.
All right. I'm opening it up, and Tammy, you can, if you wouldn't mind, just reminding people of how to unmute themselves. And we have other palliative care experts and many people who may have an interest, and questions and comments are welcome.
Sure. So again, if you hover your mouse over the bottom of the screen, you'll see a mute button on the lower left-hand corner. Just click on that. The red line will disappear, and you'll be able to ask questions. I can unmute everyone, but I think that might be a little chaotic, so I'll let people start by unmuting themselves.
Hi, this is Leslie Emmerich. I'm the Director of Public Policy for the Washington State Hospice and Palliative Care Organization. Can you hear me okay?
Yes.
One of the questions that I have, and it's come up at a number of meetings that I've had with the Healthcare Authority and DSHS and others these days, is this patchwork quilt that Pat was referring to early on about how palliative care is funded. And the person in charge of these meetings recently at the Healthcare Authority was surprised to hear that there isn't really a good palliative care funding mechanism or codes that work well specifically for palliative care. And when I talk to the folks in the hospice community and the home health community, it really is a patchwork. Some bill it through their home health program, some bill it through their hospice program, some do it through charity care because they have no billing mechanism for it. In an ideal world, what would it look like to you if we had the proper funding mechanism in place for palliative care?
Well, I think the healthcare system is still really built on the physician or nurse practitioner billing for services, and that being enough to sustain the whole enterprise. And when you're dealing with an interdisciplinary model like palliative care, you need to have a funding mechanism that's going to recognize the value of spiritual care, of pharmacy, of social work, of nursing, and the services they provide that aren't separately billable. And so there are insurance plans, private insurance plans that are creating palliative care benefits. There's a lot of lobbying going on to try and, as our healthcare system moves forward, but we're in such a time of incredible uncertainty right now with healthcare in a broader sense, let alone to focus in on palliative care, that getting those sorts of things in place. But the more that you have an organization that is both at financial risk as well as the provider of clinical services, the more integrated it becomes and the more it makes sense, because right now my hospital system pays for our palliative care program. The benefits financially often aren't coming back to that system. We're preventing extra costs to payers by fewer ER visits, by fewer ICU stays and things like that. But in the current funding mechanism, it's not the people paying to fund the team that are getting those economic benefits. In fact, in some instances, they worry that it's a revenue loss because maybe we're cutting down on admissions that would be profitable. So it's a very complex and difficult scenario without a major change in the funding mechanisms.
Other questions or comments?
And Leslie, I'd be interested if you had a response to that. Does that resonate with you, or do you have other ideas?
You know, it seems like one of the things that Pat's been working on, and Pat, you can tell me if I'm on or off base with this, is that some of the grant funding that you're looking at is to set up a model for palliative care funding. And I think the thing that resonated with me when you first brought it out was that this is an interdisciplinary model. And that's the hard part, is that it's a bunch of different pieces that there's no code that says we're going to provide palliative care, which means this is an interdisciplinary model, which we're going to bring in all of these. I guess what pops into my head is bundled services like we have for hospice. So I know that the Healthcare Authority is very interested in providing palliative care, but I think that it would be really valuable, since they fund Medicaid, to have a conversation with them about how the state can set up a better model for palliative care, specifically for Medicaid patients. And yes, we did pass legislation a few years ago, and I believe it was Regents that was behind that, and Cambia Group, that allows private insurers to pay for palliative care. And I'd be interested to see the models that they have set up. Maybe, Pat, that's something that we can look at for this group. But I also think we need to be having a conversation with the Healthcare Authority about how we pay for palliative care in Washington State, because legislators love the word palliative care. I'm not sure they understand really what it is. And we certainly don't have a mechanism in the state to pay for it. So whatever we can do to move that forward would be a good thing.
Leslie, I just say briefly that you're on the money, and that's an intended conversation. I think about it two ways. We're caught between worlds right now. So if we think about it in the number of times we see people weigh, Minnesota in a project like this was successful in getting a 10 home visit benefit across all the payers in their state. But if we think about it differently and kind of the new paradigm we're moving for, and particularly in rural where volume is not your friend, then I think about a payment system that pays for the capacity to offer the service, no matter how many times the service is offered. So what does it take to have the people available to perform that service, and can you cover those costs with a reasonable amount, and at least a fixed cost, and then you look at what you need to do maybe as a second piece of that to cover variable costs. So I think we're, again, between worlds, but this is an important part of this whole effort, and augmented, not solely, but augmented by volunteer efforts. And we have, some great efforts in the state where people are using their talents to contribute to this. But we know that that's wonderful, but we also need the payment alongside of it. So other questions or comments? I often threaten people that I was trained as a therapist and I can tolerate silence, but it is a little bit harder in this format. I have more questions, but I'm going to give just one more pause and see if somebody else has one before I launch in with maybe one last one before we wrap it up here.
I have a question or a comment.
Thank you.
And what I am thinking, are people looking at a model that's similar to hospice in terms of funding, just a per diem like hospice gets as a way of funding palliative care? Because I certainly think that there are so many different venues that it can be offered in, but particularly when we're looking at the home side, that may be a way to fund it, in particular with Medicare. To try to do that kind of funding, even setting up a pilot project.
Yeah, this is an interesting tidbit. So I had the privilege last week of touring around and talking to some rural home health and hospice agencies, and it was a wonderful education. And And I learned that we did, in fact, have a palliative care Medicare demonstration agency in our state, one. And but they had set it up that the patients, to be eligible, had to meet all of the same criteria as they do for the hospice benefit. So that created not the kind of open door we'd hope. And then I also just want to share that what they offered them was a $400 per month stipend per patient to offer that program. And for those of you who are close to home health at all, you'll not recognize that that's pitiful. So we're hoping they learn from this demonstration. This is the cohort 1 for Medicare, and there's supposed to be an additional cohort, and we're hoping that they have learned that that's not enough money and that they've made the front door too tight. So I choose to remain hopeful, and I think there are so many good hearts and minds in Washington that are dedicated to this, and it's the right work, it's the right thing for the communities, that we will find our path. So I want to, yeah. Jenny, you look like somebody.
I don't know how far it's gone yet, but I know that the American Academy of Hospice and Palliative Medicine has an alternative payment models working group. And they've put quite a bit of work based on some pilots on the East Coast in accountable care organizations where funding a limited home-based palliative care service was demonstrated to have substantial improvement in satisfaction, quality, and costs. And so using that, they're looking at having some sort of bundled package built into Medicare. It's a proposal at this point. How far it's gone thus far, I don't know. How far it will go, I know even less. But that is being promoted. And they're actually looking at it at kind of a tier level, the person who has fairly minimal complex illness needs all the way up to the person who has extremely complex illness needs. And there would be some modifiers that would impact the bundled payments, because somebody may be fine seeing their palliative care team once every 3 months. Others need to see them multiple times per week. And so how do you build that in there as opposed to just the traditional widget counting methods? So stay tuned. We'll see where that goes.
Well, I want to thank our speakers, Dr. Greg Vandekief and Dr. Stephen Grossman, very much. And thank you all for being with us. And give just a plug that next week, same time, we will be talking about telepresenting. PNMs we'll be applying the sort of the gift and skills of telepresenting to the idea of palliative care. And so again, thank you for being with us, and there'll be more to come. We see this as the beginning of a series of palliative care education for rural health. Have a great day.
Thank you very much.
Thank you.
Thank you so much, Pat.